We're going to move on to keratoprosthesis and get an update on indications and long-term outcomes from Geeta Iyer.
This was a child that visited our institute way back in 1995 with bilateral ocular surface keratinization following Stevens-Johnson syndrome at the age of 10, at which point in time we had no solution to this problem. The mother of the child continued to be very persistent, visiting us every 6 months for the next 10 years, at which point in time we went ahead with the MOKP procedure in one of his eyes for visual rehabilitation. And almost 15 years later, the boy, now a young man, continues to maintain a visual acuity of 20/20 that he recovered following the procedure, working for a multinational company. The learning and experience from such success stories and otherwise has formed the basis for keratoprosthesis, indications, and long-term outcomes, the topic for my talk today. I have no financial interests to declare. Broadly speaking, keratoprostheses are categorized into types 1 and 2 as listed here, the indications, technique, and complications of each of which vary significantly. However, the deciding factors, which are patient-related, are broadly the same across all keratoprostheses, with specific emphasis being stressed on finger tension or intraocular pressure that needs to be addressed aggressively if high, the age at the onset of blindness, which determines the occurrence and severity of amblyopia, and the estimated visual potential in these patients, which determines the type of keratoprosthesis that you would choose specifically for the type 2 Kpros. The type 1 keratoprosthesis is basically performed in patients who have moist eyes with good blink, no exposure, and no underlying immunological conditions, and are further divided into subdivisions based on a hierarchy of prognostic categories, with the best prognosis being noted for patients who have multiple failed grafts, aniridia, viral keratitis, and silicone oil-filled eyes. Type 2 keratoprostheses are reserved for the more severe conditions, severe ocular surface diseases with immunological conditions such as SJS or OCP, severe dry eye, severe phonacial shortening, and lid deformities. However, the decision-making in these patients is a bit complicated. There are not too many centers across the world that perform all the different types of type 2 keratoprosthesis. It was way back in 2003 that we initiated the MOKP procedure in India for the first time under the guidance of Professor Giancarlo Falcinelli, and subsequently we had published a very good anatomic success of close to 90% as a result of the first 50 cases in 2010. We subsequently ventured and initiated the other types of type 2 keratoprosthesis, such as the Lucia type 2, the Boston type 2, the osteokeratoprosthesis, and more recently, the Lux keratoprosthesis at our center. And having had experience with all the different types of type 2 keratoprosthesis, the OKP continues to remain the first choice of treatment in patients who are chosen for the type 2 keratoprosthesis. The estimated visual potential also determines the type of procedure that we would choose in these kind of patients. It's the water tightness of the optic-haptic junction that the tooth provides in the OKP, as well as its resistance to melt, that makes the OKP far more superior to the other type 2 keratoprostheses that are currently available, but it is equally important to also consider the time-consuming and demanding nature of the surgery, as well as the cosmetic outcome when a decision is being made regarding the type of surgery. The deciding factor also includes certain factors which are surgeon-related with respect to the training that the individual has had, the access to the setup that is required for performing these kind of procedures, and the strictness of follow-up protocols with each of these different types of keratoprosthesis. At Shankar Nethralaya, our experience over the last 16 years spans more than 250 keratoprostheses of all the different types. We've done the procedure in more than 100 eyes of Stevens-Johnson syndrome, close to 100 eyes of chemical injuries, with a functional and anatomic outcome more than 70% across all the keratoprostheses at differential time frames of follow-up. These are some of the complications that we have had. In fact, complications are the norm rather than the exception in patients with keratoprosthesis. And to put it in a nutshell, it is periprosthetic tissue loss defined as graft melt or laminar resorption that was noted to be most common across all keratoprosthesis. Complications were more common in the type 1 keratoprosthesis in patients with chemical injuries and in type 2 in patients with Stevens-Johnson syndrome. Most complications occurred after a 5-year period with the OOKP, whereas with the type 1 keratoprosthesis, most complications were seen as early as 2 years following the procedure. The average number of interventions that were required following each keratoprosthesis was somewhere around 2 to 3 per eye. We've had to introduce modifications in some of these procedures as measures to address and prevent laminar resorption, especially with the MOOKP, where we now use the bone morphogenic protein to regenerate the bone in situ, and do a prophylactic bone augmentation in some patients in order to delay or retard the process of laminar resorption. Lucia type 2 keratoprosthesis was something that was introduced in these patients where we required a 1-axial length economic variant of the Boston type 2 Kpro, which would protrude out through the mucosa. A recent modification, the Lux keratoprosthesis that uses a titanium sleeve, which is more biocompatible, has also been performed in 4 eyes at our institute. We've also done the Boston type 2 keratoprosthesis through the oral mucosa instead of the skin, which does work in some of these situations where you cannot do it through the lid, or you have to use the mucosa for certain other reasons. The Lucia type 1 keratoprosthesis is an economic, again, 1-axial length variant that we have used in patients in a developing country like ours. This patient was our first type 1 keratoprosthesis, and the indication was in an oil-filled eye, and she has the longest follow-up over 11 years. We have a large series of type 1 keratoprosthesis in 22 oil-filled eyes, and we have close to 40 eyes across all the keratoprosthesis that have been oil-filled as indication for keratoprosthesis. We've done 4 pediatric Boston type 1 Kpros. The long-term results are not very good, but this is one of the patients who has retained the keratoprosthesis for a long follow-up period of 9 years. We've done 33 eyes of Boston type 2 keratoprosthesis, which at least in the short and mid-term seems to have encouraging outcomes. We do come from a developing country where we understand that the climate and the agrarian population of the country does predispose these patients to infections, and we recently published the current global scenario and a broad Indian perspective of keratoprosthesis in the Indian Journal of Ophthalmology. To summarize, we have multiple options to choose from today. All we need is a relatively functional optic nerve and a relatively functional retina. And it is equally important not just to choose a patient for keratoprosthesis, but also the keratoprosthesis for the patient. These are some of our patients over the long period of follow-up with the OOKP and their long-term outcomes, where all of them are doing very well in their chosen respective fields. This is truly a procedure that transforms lives. This was a patient who presented to us with a retinal detachment in one eye. The skin grafting was done elsewhere, and it was an entire team that had to work on her to bring her to a vision of 2200. And in 2019, 5 years after she presented to us, she now works as an arts teacher in a local school. This is another patient who was actually query PL when she presented to us with a retinal detachment in the eye. We had to do a retinal detachment surgery with oil in the eye. Subsequently, went on to do a Boston type 2 keratoprosthesis, and at a 1-year follow-up, she maintains a vision of 660 in her eye. So that basically is an update on the various different types of keratoprosthesis that is currently available. It is not possible without teamwork, and I would like to acknowledge all those who have been responsible to make this possible, especially our mentors, and most importantly, our patients. This is our team back home in Chennai, India. Dr. Bhaskar is here, and I come from Chennai, India. Thank you for your patient hearing.